Welcome to this comprehensive explainer on subdural EMPYEMA. We're going to meticulously trace the complete clinical pathway of this critical condition, making sure we don't skip a single important detail so you walk away with a crystal clear understanding of exactly how to evaluate and manage it. Let's get right into it.
Here's our roadmap for today. We'll be covering the evaluation of subdural EMPYEMA, the massive risks associated with lumbar punctures, surgical treatment options, medical therapy and seizure management, and finally, patient outcomes and prognosis.
All right, Section 1, Evaluating Subdural EMPYEMA. Let's look at how we actually identify this life-threatening infection. So when you're looking at imaging, what are you actually searching for? A subdural EMPYEMA is going to show up as a crescentic or lenticular extracerebral lesion. That's the hallmark shape. But here's the absolute crucial detail. You really need to use intravenous contrast. When you push that IV contrast, it creates this dense, unmistakable enhancement of the medial membrane right along the edge of the infection.
Just take a look at this beautifully rendered watercolor-style illustration of an MRI. On the left, without contrast, the infection is, well, it's kind of subtle, right? But on the right, once that contrast is on board, boom, that densely enhancing medial membrane is perfectly highlighted. It is undeniable.
Now you might be wondering, CT or MRI? There is a completely clear diagnostic winner here, and it's the MRI. An unenhanced CT scan can easily miss smaller lesions entirely. Sure, it might look slightly hypodense, but still denser than normal spinal fluid, but it's just not reliable enough. An MRI, on the other hand, is definitive. It's going to give you a low signal on your T1 weighted images and a nice high bright signal on T2.
But you can't just stop at the lesion itself. You have to meticulously scan the imaging for secondary mass effects, which are massive red flags for increasing intracranial pressure. Specifically, you're looking for three things: an inward displacement of the gray-white interface, compression of the ventricles, and, in really severe cases, the literal effacement or squashing of the basal cisterns.
Moving on to Section 2, the lumbar puncture risk. This is where a common diagnostic tool becomes a lethal trap.
Okay, let's talk about a massive red flag. Performing a lumbar puncture on a patient with a suspected subdural EMPYEMA is incredibly hazardous. Why? Well, remember those mass effects we just talked about? The compressed ventricles and effaced cisterns? Because of all that built-up pressure, if you alter the pressure dynamics down below with an LP, you introduce a severe, life-threatening risk of causing the brain to herniate.
Now let's say an LP was somehow already performed before the diagnosis was totally clear. If there's no underlying meningitis, the fluid is going to show a very specific parameningeal inflammatory profile. You'll see a moderate sterile pleocytosis, meaning elevated white blood cells, specifically between 150 and 600, with polymorphonuclear leukocytes being the predominant type. Glucose, that actually stays completely normal, but the opening pressure is usually going to be high. Protein will be elevated to about 75 to 150 milligrams per deciliter, and here's the kicker: organisms are almost always entirely absent.
All right, Section 3, Surgical Treatment Options. Once you've safely diagnosed this, it's time to act.
And when I say act, I mean emergent surgical drainage is required in the vast majority of cases. Trying to manage this without surgery is exceptionally rare. You would literally only even consider a non-surgical route if the patient has very minimal neurologic involvement, an incredibly limited mass effect, and they're already showing an immediate, highly favorable response to antibiotics. Otherwise, you're heading straight to the OR.
This brings us to a classic surgical debate: burr hole drainage versus a full craniotomy. Burr holes are fantastic for early fluid pus or if you have a critically ill patient with a very localized lesion. But keep in mind, up to 20% of those patients will eventually need a craniotomy anyway. Craniotomies are generally preferred for later stages, especially once the infection develops loculations or septations, because the surgeon really needs that wide access to thoroughly debride the area.
Now here is a critical surgical warning. When the skull is opened, the dura is going to look completely white. That's from the thick layer of pus trapped right underneath it. The surgical goal is to wash out that subdural space. But, and this is an absolute non-negotiable but, the surgeon must not try to aggressively scrape or peel away material that's stuck directly to the brain's cortex. If you try to remove that adherent material, you risk causing a catastrophic cortical infarction. So remember, gently wash, absolutely do not scrape.
Section 4, Medical Therapy and Seizures. Surgery alone just isn't enough. Medical management is our vital second pillar here. You have to blast the infection with brain-penetrating antibiotics, and you manage it very much like you would a deep cerebral abscess.
But there's another major threat we have to plan for: seizures. You usually want to bring in anti-seizure medications prophylactically to shield the patient. And if a seizure actually does occur, well, those meds instantly transition from being highly recommended to absolutely mandatory. Finally, Section 5, Patient Outcomes and Prognosis. What actually happens to these patients after all these interventions?
To really appreciate where we are today, we have to look back. We are looking at a staggering historical triumph for modern medicine here. Back in the pre-antibiotic era, developing a subdural EMPYEMA was basically a 100% guaranteed death sentence. No way around it. But today, thanks to the exact clinical pathway we've just broken down, that mortality rate is absolutely plummeted to around 10%. It's a complete game changer.
But let's be real. Survival doesn't always mean walking away completely unscathed. While things do improve, the data shows that 55% of patients still have some form of neurologic deficit at the time they're discharged from the hospital. Breaking it down, 34% are going to face persistent seizures, 17% will deal with residual hemiparesis, and as we noted, the modern mortality rate still hovers between 10 and 20%.
So what tips the scales toward a worse outcome? We have a clear set of risk factors. A patient's prognosis drops significantly if they are 60 years of age or older, if they arrive at the hospital in a state of obtundation or a coma, or if the infection is a result of surgery or trauma, rather than just a simple sinus infection. Interestingly, burr hole drainage is also linked to worse outcomes. The researchers think this is likely just because those patients were usually in a much poorer baseline condition to begin with. Ultimately, the fatal cases almost always feature an associated venous infarction of the brain.
And that leaves us with a really compelling final thought. When you consider that catastrophic risk of venous infarction, you really start to appreciate the absolute razor's edge that neurosurgeons have to walk. How perfectly must a medical team balance the urgent need to wash out lethal pus with the absolute, agonizingly delicate preservation of cortical tissue? It's a true masterclass in medical precision. Hopefully, this explainer has made every single step of this critical pathway crystal clear for you.